So welcome everyone to this information session for medical providers on the new Maine sex crimes kit tracking system. So glad to have you here. I'm going to go ahead and share my screen so we can get started. My name is Carly Fisher. I use she, her pronouns, and I am the Systems Advocacy Coordinator at the Maine Coalition Against Sexual Assault. I'm here today in my capacity as the project coordinator for a kit tracking pilot project that we're going to talk all about in the next hour together. And so we have lots of content to get through. So you'll see me working from a PowerPoint, but I welcome questions anytime if you want to come off mute. And we'll make sure that we leave lots of time for questions and discussion at the end. So it's up to you. Feel free to keep questions on the side as we go or interrupt. But hopeful that we'll have lots of engagement on this as well. First and foremost, I know that lots of folks on this call are already aware of the Maine Coalition Against Sexual Assault, but for those who are newer to this work, I wanted to take a minute and share who we are and why we are supporting this project. And so the Maine Coalition Against Sexual Assault is an organization, but it's also a coalition of organizations. And so here at MICASA, that's our acronym, our primary role is to serve and support and represent the centers who do the direct service sexual violence advocacy in the communities. So you may know your local sexual assault provider, and it's our work to represent them in a legislature, to train them, to offer support, and to support some of this kind of macro level 50,000 foot anti-sexual violence work in the state. And so this kit tracking system is part of that. And we're going to talk a lot about sort of what that is, why it's important, and where this project came from today. I also know that there's a lot of wonderful expertise from a medical lens, from an advocacy perspective, and lots of other sort of wonderful community supports on this call. So I hope that you'll feel free to speak up and chime in and share your expertise as well. You may also notice that we have these other three programs here too, which I should have said. So again, we serve and support the sexual assault support centers. We also oversee the Maine network of children's advocacy centers, which provides forensic interviews for youth when there's a concern about sexual abuse. We also convene the Maine Sex Trafficking and Exploitation Network, as well as the Children's Safety Partnership, which is the curriculum for sexual education K through 5 in Maine. So for today, we're going to start broad with just a brief overview of what the Maine Sex Crimes Kit is. We're going to talk about kit tracking systems. Then we'll talk about the pilot project, what we're hoping for from you all as medical providers. And finally, we'll make sure to spend some time on contact information and resources. But again, we'll leave some time for questions and information in there as well. So to go ahead and get started, I know there are a lot of safes on this call already, so I'm hopeful that a lot of this is going to be a review for most of this call. But again, we know that lots of folks are here from some sort of various sectors. And so I think it's important to spend some time talking about what this actually is. What are these things that we are tracking? So the Maine Sex Crimes Kit, that's what it's called. You might also hear us refer to it as safe kits or kits, but it's a standard state issued evidence collection kit. So they look like that in the photo. They're full of swabs, look like Q-tips and sort of test tubes. But what those kits are, is they're a way that we can preserve forensic evidence on the body following a sexual assault. All completed kits are stored in law enforcement evidence lockers. So they're collected in hospitals, picked up by law enforcement, and then eventually stored as evidence. But the survivor who is involved has a choice as to whether their kit is reported or anonymous. And we're going to talk a little bit more about what that means. But we'll get there in a second. So first, I think it's also helpful to really understand what happens in the life of a kit, because essentially what a kit tracking system does is really track the movement in the life of that piece of evidence. So they all start as blank open kits. They go from, sorry, not open, as sort of blank kits that haven't been touched. They start at the crime lab and they send them out to hospitals. So the crime lab is really kind of the distribution phase of this. There's one state police crime lab in our state. That's where all evidence is tested. They're shipped to hospitals where, when patients present in emergency rooms with sexual assault, medical providers, some of whom have something called a SAFE certification, which stands for Sexual Assault Forensic Examiner, which is extra training in being trauma informed and some sort of extra practice in collecting these kits. Sometimes safes collect that evidence, but it doesn't have to be a safe. It can be any licensed medical provider in an emergency room setting that can collect that evidence. Oftentimes there are advocates there. We hope that there are sexual assault advocates there as well. But that evidence gets collected using that state-issued kit. Then a survivor decides whether they want to make a formal report of that assault to law enforcement. Totally up to them. Law enforcement comes to pick up that kit, whether it's reported or anonymous. And we're going to talk more about what happens next there, because that little asterisk is telling us that if there is a reported kit, there are other steps in the middle, which we'll talk about. But regardless, it ends up getting stored at the collecting law enforcement agency for 20 years minimum. And eventually it can be destroyed after that 20 years. And so here's a little bit of the difference between these reported and these anonymous kits. We know that not everyone who receives medical forensic care at a hospital wants to report a sexual assault to law enforcement, but we also know that a lot of people do. And so that choice stays with the survivor or the victim or the patient. I think you're mostly going to hear me use the word survivor. That's often what we choose to use at the coalition. Victim might be appropriate if we're talking about a current criminal case, but you also might hear patient if we're talking about this from a medical lens, but I'm probably going to use survivor most. So the survivor, victim, patient gets to choose whether or not they report it. If they do report it, there are going to be some extra steps that happen in the middle here between the time when it gets picked up and when it eventually goes back to sit on the shelf in storage. So if the person chooses to report the crime and submit this as part of their report, yes, there will be a formal police report that a law enforcement officer will come and take. Yes, the survivor and the person who perpetrated that crime, if the person is known, which they almost always are, they will be named on that. And the law enforcement agency that has jurisdiction where the assault occurred will be the one to pick up that kit and store it. So for example, perhaps a person reports to St. Joseph Hospital in Bangor, but the actual assault happened in Portland, then Portland PD would be the one to come and pick up that kit when it's reported. They have jurisdiction over that crime. And it may or may not be tested for DNA, depending on whether a prosecutor orders that testing. So law enforcement will have 60 days to investigate that crime and pass off their findings to the local prosecutor, at which point the prosecutor will say, yes, test that for DNA evidence, or no, we don't want to test that this time. All of that is true for reported kits. And once all of that happens, it will eventually go back and it will stay on the shelf, again, in the jurisdiction where the assault occurred. So in my example I just gave, it would go back and it would sit at Portland for 20 years. Anonymous kits are different. So if somebody either knows that they don't want to make a police report, or they're not sure and they want to take some time to think about it, they can have a kit collected anonymously. When that happens, they go to the hospital, the kit gets collected, police officer comes to pick it up, but there is no formal police report. That can happen at any time. So if somebody chooses to have an anonymous kit collected, they could come back in 3 weeks, 3 years, 15 years, 30 years, really. They could come back and report that at any time. But the statute of limitations for gross sexual assaults, which is the statute for what we often consider rape or sexual assaults, that's often language we would use there, is 20 years. But anytime within that 20 years, which is why we keep them for 20 years, you can make a formal police report that crime, and have that kit be used as evidence in that crime. When it's an anonymous kit, up until that person chooses to change it, if they ever do, to a reported kit, the survivor and the person who perpetrated the assault will not be named. There is no personally identifying information in that kit. And the law enforcement agency that picks it up and stores it is going to be whichever agency has jurisdiction over the treating hospital. So back to my example, if it was the patient shows up at St. Joseph's in Bangor, the assault happened in Portland, but it's an anonymous kit, Portland PD is never going to know because they're not going to get a police report. So Bangor PD will pick that up because that's where the hospital is. Anonymous kits are never tested for DNA or other evidence. Again, unless somebody changes their mind later, opts to report it, and goes through that whole process. I'm going to keep us going, but again, plenty of time for questions and clarifications at the end. And so a kit tracking system is really exactly what it sounds like, which is simply a software system that functions like a package tracker for kids. I took the liberty of inputting a very similar one that I received in my own personal email the other day with the shipment from Home Depot. It basically does exactly that. So if you want to know where something that you ordered is that's coming from Home Depot or Amazon or wherever it may be, um, you might want to know, has this order been processed yet? Has it been shipped? Is it out for delivery? When can I expect to have this on my front porch? You can log in. You're not going to get a lot of details, but you will see where it is in process. That's exactly what this kit tracking system does. So we know that when somebody goes home from the hospital, they receive that kit ID number. When you type in that kit ID number, anyone can determine the physical location of a kit anytime, anywhere, but there is no personally identifying information in there. Okay, so there's no risk that if I get a hold of somebody else's kit number, the most I'm ever going to see is where it is. Is it sitting at Bangor PD? Is it being tested? I won't know whose it is. There's really not a lot of information that can leak out, just this piece. And I'm going to show you what it looks like in a second, but before we get there, I think it's really important to understand why we care about this. Why have we pushed for this for years? Because in Maine, there has been a lot of advocacy work to get this done for years and years and years. And we're excited to finally be at a point where we're implementing this. But first and foremost, a kit tracking system ensures that all kits can be found easily and immediately. We know that law enforcement manages their own evidence, so law enforcement knows where things are. However, whenever somebody is sort of in the wake of something traumatic, including sexual assault, but it could be other things too, we know from decades of research that that sort of trauma response makes it really hard for people to retain information that you share in the moment. So especially when survivors are presenting for medical forensic care, we're giving them a lot of information. We know that as advocates, we know that as medical providers. We know that the things that we say may or may not be encoded in that moment. So people aren't going to remember where their kit is supposed to be, whether or not it's going to be tested for DNA. We can sort of expect that they might need some support in remembering those details later. Especially, again, thinking about anonymous kits. Imagine someone submits an anonymous kit and then 10 years go by and they decide to report it. They're very unlikely to remember where that thing was supposed to end up 10 years ago, right? So this kind of system, once they get hold of their tracking number again, they can log in on a web-based browser from their phone, from their laptop, from their whatever technology we'll have in 10 years, and they can figure out exactly where that thing is easily and immediately. We also know that offering those consistent updates is trauma-informed and it benefits survivors. Information and options help people and give some of that autonomy back, which is really important, and we want people to have access to their own information, right? Because ultimately, right now, the only way that people can get this information is by either calling up the investigating officer or sitting by the phone and waiting for them to call with an update. And that's not good for anybody. It's not fair to survivors. It's upsetting to survivors to have to sit around and wait for someone to update you. But also, we want law enforcement to have time to focus on the investigation. That's their job in this, right? And so we don't want to be unnecessarily interrupting their workflow, and we can make an easier way for people to get the information that they need. And finally, this kit tracking system is going to be so helpful for us in generating data reports. So by using a system like this, we can get some really good and clear information that we don't currently have about how many kits are being collected statewide. Are these anonymous or reported? Where are sexual assaults happening in the state? And what kinds of resources are needed to fund the work that all of us are doing? What do we need to fund for the crime lab, for law enforcement, for medical providers, for SAFE programs? This type of information can really make it clear for us what the asks are so that we can get good grants, good state funding to support the work that we're doing with some really clear data to back up our asks. And we're also a little bit behind the curve, to be totally candid. So about 2/3 of other states use some kind of kit tracking system. There's really three ways that other states have gone about this. And so most of them have purchased commercial kind of off-the-shelf products. So when we say that, we're talking about private products developed by third-party vendors, right? So think like TurboTax is an example of like an off-the-shelf commercial software product. A lot of us buy TurboTax so that someone else can do this for us, right? There's some really, really stellar commercial off-the-shelf products. We looked at a lot of them pretty closely and we're pretty compelled, but they're really expensive for the most part. And I think the project advisory committee on this started getting nervous thinking about essentially buying something that might have a price tag of $100,000 a year and trying to keep that going. So I think we really were concerned that even if we could get it now, would we be able to sustain that funding? So we didn't do that. And so the other states that don't use those commercial off-the-shelf products do one of two things. They either work with developers to build their own code, kind of build it in-house, or they work with other states to borrow those codes that were built in-house. And we did the latter. So we are currently using the Idaho State Police system. So developers and state police in Idaho created a system, and they've been very willing to share their code for free with other states who want to do it. But the deal is that we have to operate, install, and sort of update the system on our own through Maine IT. Free product, no support after that. So we're kind of on our own now, but it's a much lower budget option, and it's completely customizable to us because we know that all states have slightly different needs, slightly different laws about how this system needs to function and support it. So we're really excited about it. And there are lots of other states who have used the system and had sort of, I think really positive experiences overall. And so Idaho obviously uses it. North Carolina has really done some stellar customizations to it. Ohio, New Mexico, Puerto Rico have all either have used or are currently using this code with varying degrees of customization. But for the most part, we hear really wonderful things. And so I want to show you a little bit. Now the time has come. I know this is what everyone is here for. I want to show you what this actually looks like. And so in this information session, I'm not going to do a deep dive into like the back sort of user view, the back end. We will have that available as part of the training for users when the time comes. So if you're currently safe in a hospital, we will get you trained. And in that video, we'll go through all of those details. But for now, for this session, what I want to show you is what the public is going to see. So when a survivor logs in and they want to know where their kid is in the process, there's a couple of things that they're going to see. So I'm going to stop sharing for a second so that I can show you this system in Chrome. Can you all see that okay? This is the developer's site. So you see up in this kind of top left corner where it says DEV. This is just kind of a test site for now. This is a dummy site. So the real one is going to go up pretty soon, but it's going to look exactly like this to start. And again, this is totally customizable. So over time, we can make this page look however we want it to look. We can change this language, we can add other resources, we can do whatever we want. But to start, this is kind of what it's going to look like. Idaho's is virtually identical. So a patient will go home from the hospital with some kind of brochure or index card or something that has a link to this site and their kid number. So up here in the right corner where it says serial number, let's say my kit is number 5002. I can look it up. And this is what I will log in and see. So this example that I'm giving you is an example of a kit that has gone through the full testing process. So that means this is reported, right? We can see kit number up here. We can see that again, these are all clearly just our dummy tests. This obviously would not happen in a matter of 2 days, but it starts at the lab. They ship this fresh unopened kit over to Maine General as an example. Maine General collects the kit, sends it off with law enforcement. In this case, in this example, we'll say Maine State Police is the collecting agency. At some point in here, we know that Maine State Police has sent their evidence to the prosecutor that would have jurisdiction here. Prosecutor has said, yes, let's test this. We want this evidence. We want this DNA evidence. It goes to the lab, it gets processed, and it gets sent back to Maine State Police for storage. You can see a couple of other sort of data points here. For example, if they had sent this into the DNA database, which we call CODIS, you can see where that happened. And in this way, it's just a slightly different view if you want more of a written view. This does not replace a chain of custody. So medical providers and law enforcement still need to be engaged in those processes, but it's helpful for survivors who may want that live update. Okay, so a survivor could log in and say, perfect, it's tested, done, check. Now I can call my investigator and figure out what the next steps are, right? Or hopefully they get that call from the investigator without having to call, right? But it's a little bit more information. I'm going to show you another example. I'm going to show you 5007. This is an example of what an anonymous kit would look like right now, or a kit that's reported but untested for whatever reason. Again, starts at the lab, gets sent to Maine General where it's collected, gets sent off to a police agency to pick it up. So again, if it's anonymous, it's going to stop right here. Nothing else is going to happen until or if, the patient decides to report that crime. It's just going to stay at Maine State Police for 20 years. And ideally, eventually this will reflect down here. We still have some tweaking to do, right? And up here, this is another thing that needs to be tweaked too. Ideally, we don't want it to say ready to send to lab because that's confusing. We want an option for anonymous kits to say, status, waiting in evidence or something like that. We'll have to update that. But that's the type of work that we're going to be doing in the next couple of months, really, a couple of years, really, of really kind of finding those tiny details and making sure that they're customized to reflect what we want them to say. And that's where I need some help from you all, which we'll talk about. Again, same view. You can see some of the written steps down here. I'm going to stop sharing and go back to my PowerPoint. And when I send out these slides, you'll have a link right here. So you can click on that and you can go in and play and test whatever kit numbers you want. Again, bearing in mind that these are fake kits. These aren't real. These are just dummies in the system for us to practice. And so we're close to sort of our Q&A period here too, but just to answer some questions about where we're at with this pilot project. Lots of states have sort of opted to roll out a system like this statewide to begin with. But here in Maine, we opted to do things a little bit differently. And candidly, especially having an open source system like this, it's kind of nice to have that opportunity to start small, knowing that there are going to be issues and customizations that need to happen. That's not like an accident. That's the reality of a pilot project, and we know that that's going to be the case. So MICASA is funded right now by a STOP grant to support this project. And we're working really closely with the Department of Public Safety to pilot the system in Kennebec and Penobscot counties. It's taken us about a year to research kit tracking options and run this thing through Maine IT's security and safety audits, accessibility audits, all of those things. But now we're ready and we're really excited to get started and to practice this thing and do a little bit of kind of building this plane as we fly it, right? Again, that's the nature of a pilot project. And so what we're really hoping is that all pilot sites, which include all hospitals, local and county law enforcement agencies, and the crime lab, start using this system on November 4th. I would have gone for November 1st, but that's a Friday, and that felt like a really bad idea. So we're going November 4th because it's a Monday. And again, our hope is that after attending this information session, folks will start to have an idea of what this is, why we're asking for it, a little bit of context for the project. And pretty soon, we're going to start sending out links to get users trained and added into this system. It's pretty straightforward. It's not a complicated system, but really what this comes down to is practice and making sure that people understand that this is a thing that we're really asking folks to use and be consistent with. Okay. Ultimately, the goal is not for this to stay with MICASA. Ultimately, the goal is for this to move onto DPS's plate. And so the Department of Public Safety will hire someone to be a system administrator for this. And at that point, we'll transition leadership on this project. And that person will hopefully, over time, facilitate statewide expansion. We're working really hard to secure statewide funding for this through the legislature. We've had some really wonderful advocates in the legislature last session and this upcoming session who are hopefully going to help us get that done. But having that funding secured would really ensure that this system is here to stay and we don't have to stress about where the money is going to come to sustain it. It's really critically important, I think, to keep this momentum going. And as we're going, especially if you're in one of these two pilot counties, it's really important that you share your feedback with us on the ground. I'm not a medical provider. I'm not law enforcement. I'm not a chemist. So I'm not going to be the one using this day to day. I've noticed a lot of things already. We have a running list of customizations, but it's really helpful to hear from you all. So when you notice things that don't work, maybe language could be better, maybe something could be smoother, I really, really, really want that feedback. It would be super helpful. So I'm hopeful that you can support us in that way. And so that's my spiel. I know I just did a lot of talking and threw a lot of information at you, but I really want to spend, the second half of the session talking about the questions that you all have about the sex crimes kits, tracking systems, expectations or asks of all of you, especially the pilot sites. But again, I know there are folks from other counties here, and the goal is that you all will be using the system pretty soon too, or questions about the future of the project. And I'm going to take us off screen sharing so that we can see each other.
I have one question.
Oh, go ahead, Janelyn.
I know our organization's probably going to ask, how will you monitor who has logins and how do you know when to get rid of those logins?
A good question. So what we're going to try and do in the next couple of days, one of my tasks is going to be to reach out to every pilot site and ask them to designate what we're calling like a site administrator. So for example, Jalen, at your hospital, maybe you're the site administrator, maybe Carrie is for St. Joseph. You folks would have a separate kind of login that would allow you to go into the system, add and delete users. So you could log, if you have a new person start, if you have a travel nurse who starts or something, you could create a username for them and a password for them. And it would be up to you as a site administrator to kind of keep an eye on that. So if someone leaves or a staff turnover, you can delete that login for them as they go. And so different hospitals can handle it differently. The best practice, I hear this from all other states that I've talked to, is that every single person who might reasonably collect a kit should have their own login and password. Others have said that they just have one person kind of per hospital that does all of that. And so I think that's up to you how you want to do that. Again, I will say that I think the best practice, consistent recommendation is separate usernames for everyone, but it's totally up to you if you'd rather just have one person doing it as long as you have mechanisms to be consistent. Did that answer that question?
Carly, a question that came up actually at the Safe Quarterly meeting on Friday was, and I don't think that we have it set this way, but maybe something we should consider when we're, editing the program, is marking if the person who collected the kit is a safe or not.
Interesting.
Um, just if it would be an easy way to like determine that, when we can pull data, it might be a piece of information we would want down the road.
Yeah. That's exactly the kind of feedback we're looking for. So I've got my handy dandy notebook right here, scratching them down, but I have got a big spreadsheet working with Maine IT. So that's exactly the kind of thing that we'll put it on the list. We have a couple that are marked as really high priority, like it's critically important that this customization be made before November 4th rather, so that we can get started and have consistent data. And then there were going to be a couple others that are kind of on the list of future asks when you have time. But that's exactly the kind of feedback we're looking for. What other questions do folks have? Or I would also welcome just sort of thoughts and reactions.
I just had a quick thought about our advocates being able to be helpful with helping survivors down the road retrieve their number. So typically when I go, because I don't think this is a consistent practice around the state, and certain people would probably do it differently, but I usually get the sticker of the patient's name and all that information, put it on my paperwork that the patient signs, and then get one of the stickers from the sex crimes kit and put that on the paperwork, and then document like what that is in case the person calls back. Then I have that to be able to share with them if they lose their card. But obviously, that's not a mandate. It's not anything that anyone has to do. I'm just wondering if we want to think about that as a practice that advocates are helpful with that. Although, I think program to program, each director is probably going to be making the decision of how much information they want to keep or not. So it's just something I'm like processing and wanted to say out loud. Just maybe we could have a conversation at a director's meeting about this. It just makes me think about how much information do we want to have? Do we want to be helpful? If a survivor calls 10 years from now, and wants to call us instead of the hospital to find their number, or however that might work. So just something to think about, and that I can be thinking about to bring up at the director's meeting.
Yeah, I think that's a great question to bring up. I guess I'm curious, and I'd put this out to some of the folks on this call too. If somebody did lose their kit number, what would they do right now? What's kind of the practice? And is this a standard statewide practice, or is this going to vary hospital to hospital?
I think it depends on who the patient feels comfortable calling. So they may call their advocate, and our advocates do the same thing. They have a sheet, like an info sheet that is in the teal folder, and they take a copy of the kit number and stick it on there as well. Along with where it's going, like Bangor PD or where else. And then we also have the card that comes in the kit that tells them where their kit, their kit's going. But that's probably going to get lost, right? Like, that's an easy thing to get lost, or maybe it's not safe for them to take with them. So sometimes they don't. But I would say it depends on who they feel comfortable calling. So sometimes we get people who just call directly to the hospital looking for that information days later, weeks later, years later. And then other times they probably call Advocate to help facilitate that. But that was my other question. How are we going to give directions to the patient on how to utilize the website and how to access it?
I can tell you my thought, and I'm totally open to feedback from anyone who thinks there are better ways to do this. I think I am generally partial to resources that will link us to websites that we can easily and immediately update as needed, rather than printing up a whole brochure with information that may change as this pilot progresses. So my original thought was like a brochure, right? Like, what's the pilot project and where is this going to be? And then I thought, that feels kind of tricky, because as that info changes, I think we want to be able to be nimble in how we change and redistribute that information. So my current thought is some kind of like index card that maybe has a QR code that would link to this website. And on that website, I think we link something that would send someone to the Mikasa website with a full FAQ on what is kid testing, and all of that information can sort of live on a live website. But part of the reason why I want a Mikasa link there too is so that we don't have to go through main IT every single time we want to update a little bit of information. I think it would allow us to just act a little bit faster, and be linking advocacy services every time, which I think is really important here, especially when we're talking about folks who are 2 weeks removed from the hospital, 4 years removed from the hospital, right? So I think that having a QR code index card with kit number right at the top that would link you to both the site and to a site where we could monitor essentially an online brochure is my instinct, but totally open to feedback and other ideas about what might be more effective.
I think that's a really good idea, although we'll have to actually have the web address there as well, not just a QR code, because some folks don't have phones. But I really like that idea, because essentially what we've learned, especially with the kits, is that paper is like a vehicle. As soon as it leaves the lot, it's depreciated, right? So it's like outdated as soon as it goes out. And like I've been scratching out 90 days on my consents and on those little cards, and changing it over time. And so I think that a link to the website which will always have the most up-to-date information is the smartest way to go, but making sure we have it accessible, like both options.
Awesome.
I also think we need to limit how much we're putting on paper. I wish there was more creative ways, because we're sending these victims, survivors back into situations that they might not want documentation of this stuff with them.
Yep.
And if this piece of paper plus their kit tracking number is in one hand in a discharge, they then someone has full access to all that information.
Yes.
Maybe.
The only piece I would add to that, though, is that, again, so part of the system is that even if someone gets your kit number, there's still very, very, very little that they're going to be able to see, right? So if somebody does go home into an unsafe environment and someone does get that kit and tracking info, the most dangerous part there, right, is that they know that they went to the hospital, right? But the actual tracking system, they could type that number in. All they would see is like which PD is storing it, and maybe if it got tested for DNA evidence. And it would only get tested for DNA evidence if it was a reported crime. So presumably that person causing harm or who has caused harm would already know that had happened. So there's very little information there that they would get from this system that they wouldn't get just from finding sort of sexual assault paperwork on someone's table. Do you know what I mean? But I hear you on the paper piece overall too, which I think is another reason to sort of move a lot of this stuff online. I think that's safer and more accessible for a lot of folks.
I think if the sticker, I agree with Carrie, like always on those cards, you're having to take out the 90 days and put on a new one. How about just a sticker that you can put on with the website and that go on the card? Because there's enough room on the bottom. I don't know.
Yeah,
until
And I-
the pilot program is done and then it's concrete.
yeah,
I was gonna add if it was something small, like I know for the one of the cards that we have is like a wallet size. So if they are worried about someone finding it somewhere, they can tuck it, but know that it's there and they're the only one that would look there maybe.
yeah,
I think that also like in those scenarios, because I 100% appreciate what Jane Lynn's saying too, because you know, there's plenty of times when we can't even send that card out.
Yeah.
So we wouldn't want to be able to send out the QR either. Just really like reiterating how they can access that information at a later date, right? Like by utilizing their advocate or calling advocacy services, or even calling if you have a safe program or whatnot, or having a designated person at your hospital. That can help you navigate that at a later date. And so sometimes like that's easy to remember, like, oh, I can just call Main General when I'm ready or want to check, and then like they'll help me navigate that. Or you know,
yeah,
so I think like that would be important. And I do agree that making it like smaller, like index size, like less than, you know, like credit card size.
Yeah.
Because the one that's currently, also the kits are getting updated. They're in the process of rulemaking and getting updated. So I think that little postcard just needs to go away anyway. It's not great. And I had a lot of feedback on that, but one of the things is that it's a weird size.
Yeah.
It's like too big for a regular like wallet, but it's not big enough that it gets like it's easily lost. So it's kind of like,
Yeah.
But so yeah, having it a size that would fit somewhere would be good.
right. And so, yeah, exactly. To raise up, I think what both of you just said, Carrie and Jane Lynn, I think if you're sending someone home and they can't take paper materials home, it's like, if you remember nothing else, it's call back the hospital anytime. Call the Mikasa helpline anytime. Like those are the two resources. If you can go there, we can help you figure out anything else, right? I'm curious how do those conversations happen now for medical providers in particular? I mean, do you have many patients that feel like they can't take paper home, and how do you talk to them and help them sort of understand what to do when they need to call someone?
I think it's pretty rare. I mean, most people walk out the door with their teal folder, and in their teal folder it has everything. But in those scenarios where maybe it's not even necessarily a safety thing, but like maybe they're unhoused, right? And they're like, I only got like I don't need all of this stuff, or this is too big or whatnot. So like picking and choosing what they can take, what's easily carried or accessible for them. And then it's really like reiterating to call. For us, it would be rape response, right? And so like trying to sneak the chapstick out the door with the number on it and things like that.
Yeah. Yeah. Okay, so I'm hearing something small, either wallet size, maybe a sticker, something that's not going to take up a ton of space. Great. What else is coming up? Other thoughts, feedback, questions, concerns?
I think in the future, we should figure out how to get that added to the kit. Because right now the Mikasa pamphlet is in the kit. And retroactive VC paperwork is in the kit. So we should probably look at how to do that in the future. But in the meantime, I guess making sure that we do have access to the card, right? So having it be standard in the teal folders that come to the hospital, but not all hospitals are getting advocates right in for numerous reasons. And so how will the hospitals also get those? So we can just make sure we fill that gap too.
Do you think that needs to happen before the rulemaking process is complete? Or do you think we could add that in like 12 months?
I think we'll have to ask Allison. We'd have to ask Allison if the extra stuff is part of rulemaking or not. Probably is, just because of how nitty gritty it is. But I know it's coming down to the wire, but I'm sure it would be an easy add if there's time.
Yep. Any other thoughts, questions? I think really all I would add, I mean, I'll put up contact info in a second here. But I think really just in terms of kind of closing thoughts, it's been a really, frankly, fun project to coordinate. I've talked to so many states, chemists, law enforcement, advocates, directors of these safe programs in other states. I've heard a lot of different perspectives on what makes these programs successful, what makes them hard, what the sort of anticipated barriers are. Virtually everyone that I've talked to, especially those using this system, has said the system itself is not actually hard, but like compliance is the hard part. It's really hard, especially when there's, travel providers and there's turnover and law enforcement. There's so many troopers out there. It's just really tough to get the information out there and have people using it consistently. And so I think that's so much of what this project is and what the ask is of all of you. I think everyone's really on this call, especially folks that I know, at least I know, have a lot of sort of influence and sort of clout at their organizations and their hospitals. And so I think as much as we can, it's not time intensive. It takes maybe 2 minutes to log in and fill in this information. But really figuring out how we can build this into policies and protocols, how we can get this message out, support safes, support providers who aren't safes in doing this, who don't do this all the time. I really would ask for your support and your brain power and thinking through how we can sort of build this into become muscle memory in hospitals, and how you can support troopers too, especially knowing that you may get a different police officer every single time. Like, what can you all be doing as medical providers to help them understand and remember that this is part of, a hope and an expectation of them as well. Just kind of wrap this up. Last thing, at this point, you all have my contact information. We did make a second, and you're welcome to email me anytime. My email is just Carly, spelled like that, @micasa.org. We did make a second email address specific for kit tracking, just for sustainability, just to keep things easy, that all sort of requests would go there. So however you prefer to contact us is fine. And I've left our office number there as well. And I'm really sort of a good person to talk to about anything that would come up for you sort of in the near future. However, I will not be doing this indefinitely. Again, this will transition to DPS at some point, and we'll start communicating when that happens. But in the meantime, if you would like to talk to DPS, Trooper Mikhail Nunez has been wonderful and very helpful on this project and has generously offered to be listed as well as a contact. So especially if you have any questions that are sort of discipline specific for law enforcement, please don't hesitate to reach out to him. And last, but certainly not least, I would really, really, really welcome any feedback you have about this information session. This is the first one that we're doing. It's very possible that we'll be doing sort of something similar for other disciplines in the future. We're doing law enforcement today, but over time, we'll be thinking about victim witness advocates and prosecutors. Presumably we'll sort of redo this again in the future when we start scaling up. And so it really would be incredibly helpful to me if you would take 1 to 2 minutes to fill in an evaluation, just to help me understand what was helpful, what information maybe did I miss, any other questions or thoughts. And so I'm going to leave this here. I'll leave the Zoom room open for a little while, but I really just want to say thank you for being here. It's so much fun to be able to talk about this. It really feels like it's coming together. It's just something that I think it's rare in this work to feel like we can make such sort of tangible progress. But this is, and it's been a long time coming. And so, on behalf of all of us on the project advisory committee, several of whom are on this call, I just want to thank you for your time and your continued partnership. And please don't hesitate to reach out anytime with questions or thoughts.
Thank you, Carly. This was really helpful. And it, leads to more questions like I had mentioned before and be, thinking about that statewide. So I really appreciate all of the work that has gone into it today for this presentation, but for everyone on the committee, thank you so much. It's been a long time coming. And thanks to the hospitals that are willing to pilot this.